Dear Chair, dear audience, welcome you all on our 12 months progress report. Today I would like to present the progress of my PhD about the prosthodontic perspective of mandibular reconstruction methodologies. So imagine losing not only a part of your jaw, but also the ability to speak, to smile confidently, and to eat. So this is the reality for patients undergoing mandibular reconstruction. And to restore their oral functionality, for now we have two strategies. Dental implants can be placed immediately or after a healing period. So this is what we wanted to investigate during our meta-analysis to see the safety of these two methods. I am Zsófia, a PhD student and a dentist at Semmelweis University. My vision is that patients undergoing mandibular reconstruction receive the best possible dental prosthesis, and in order to achieve that, I would like to provide evidence-based guidelines that optimize mandibular reconstruction. For now, I have two specific goals, and they are both related to the treatment of head and neck cancer patients and also to the improvement of their dental rehabilitation. The first one is about investigating two implantation methodologies, so primary and secondary implantation in patients undergoing mandibular reconstruction. So when a part of the jaw should be removed because of cancer or other diseases, surgeons can replace it with different kind of bones harvested from the body. But when it comes to the rehabilitation of the speech and chewing and also aesthetical problems, we are using dental implants. But for doing that, we have two different approaches. Primary implantation, which means that we are placing implants immediately during the reconstructive surgery, offering a really quick rehabilitation, and secondary implantation when there is a reconstructive surgery, and after that we are waiting a 4 to 6 months healing period before placing the implant. So our aim is to investigate whether primary implantation offers comparable safety outcomes to secondary implantation while also reduce rehabilitation time and improve quality of life. Our clinical question is about the timing of implantation, so how does it affect the success rate of mandibular reconstruction? We used the PICO model and we focused on three main outcomes: implant survival rate, implant-related and patient-related complications. And the clinical implication is that if we can prove that primary implantation is a safe method to use, then we can reduce treatment time and improve patients' outcomes as soon as possible. We started with more than 11,000 hits, and in the end we had 11 eligible full text. Currently the manuscript is under internal review, so I'm planning to submit it this week. So let me show you some of my results. The first one is about implant survival rate, which is the number of implants remaining in place after a follow-up period. We used the risk ratio and investigated 11 retrospective studies and approximately 1,200 implants. The pooled risk ratio was 0.96, which means that implant survival rate was slightly lower with primary implantation. However, this wasn't clinically relevant nor statistically significant. It means that primary implantation can be a really safe method if good conditions are met during the rehabilitation. The other outcome is implant survival rate again, but we investigated it in free fibula flaps, which are the most commonly used flaps during reconstruction. Here we saw that basically the results were identical in the two groups, and this not only highlights the success of both methods, but also the success of free fibula flaps. Complications such as granulation tissue, exposed bone around implant, and peri-implantitis were unfrequent in both groups. And again, the difference wasn't clinically relevant or statistically significant between the two groups, highlighting again that both methods can be safely used after reconstruction. So some of the strengths of our study we highlighted potential risk factors which can influence implant outcomes, such as irradiation timing, also patient characteristics, and, for example, lesion, the size of the lesion. And we identified reporting gaps in the literature to offer clear direction for future research as well. Some limitations, of course, all included studies were retrospective studies designed, and sometimes the data reporting ones were incomplete, so it was hard to pull the data together. Our conclusion was that primary and secondary implantation show comparable survival, success, and complication rates. It means that primary implantation can be a really, really good option for us when some conditions can be realized during the procedure. It means that when we have a proper and precise pre-surgical planning, when there is a collaboration between surgeons and prosthodontists, and where we follow a strict patient selection criteria, then primary implantation is a good option for us. However, when we are talking about complicated surgeries and in case of preoperative irradiation, secondary implantation might still be a safer option. Let me present briefly my second topic about the investigation of the safety and effectiveness of hydrophilic and hydrophobic implant surfaces in irradiated jaw bones. So head and neck cancer is the 7th most common cancer diagnosis, and up to 85% of the patients receive some sort of radiotherapy. And when it comes to dental rehabilitation, again, we like to use dental implants to restore function and aesthetics. But the success of implantation can be based on many different factors, such as the bone quality and density, also the surgical technique and the implant characteristics. And among these factors, we would like to concentrate on the surface characteristics of the implants, because they are one of the most developed features and because they have a crucial role in osseointegration. And there are multiple types of implant surfaces, but we are planning to divide those into two theoretical groups, like the less hydrophilic ones and the ones with increased hydrophilicity. And it is known that this increased hydrophilicity is beneficial because they provide a better cell adhesion and also a faster osseointegration. And we know that it is good when we have normal conditions, but we don't really have such conclusion regarding irradiated jaws. So again, we would use the PICO model to compare hydrophilic and hydrophobic implant surfaces, and as outcomes, we have implant success rates, implant survival rate, and implant-related complications. The clinical implication is that if we can prove that this increased hydrophilicity is also beneficial in irradiated jaws, then of course we could optimize the success rate of dental rehabilitation for irradiated patients as well. And this is the summary of my two topics with the planned submission date. And I would like to kindly thank you for your attention and finish my presentation with a quote from Katalin Karikó. If everything is always handed to you, if the red carpet is rolled out for you, then you never learn how to fight. Thank you for your attention.
Thank you very much for your report. Any questions from the audience may be raised? I know this is the last session, but we still have time to support our colleague with our questions.
Which kind of risk of bias assessment did you use, and what was the results?
We used the ROBI tool, and it was serious because of the first and last parts. So basically the outcomes and also the patient characteristics and how they reported their data. Thank you.
Any other questions you may have? Actually, I do. Regarding the first and two study and the second study, how did you define the success rate? When you just, at a given time point, you examine, yeah, I did a good job, Or no, I didn't. How did you define it as success rate?
In both studies, you mean?
Yes.
So what does it mean? So basically...
Or sorry, if it's different in the first one and the second, please make some details.
Yes. So basically, when we are talking about survival rate, we are only investigating the number of implants in the jaw bones. So we place some, and then we see how many of them are still present after a period of time. When we are talking about success rates, it's more like, or we are examining also the functionality of it. So in case of mobility, we don't talk about success. In case of inflammation, we cannot talk about success. So this is basically the difference. And the timing is, yes, that's one of our problems. That, as we could see in the plots as well, the follow-up period is really heterogeneous between studies. It would be really great to say that we investigate a success rate after 5 years, because then we have a strong conclusion, but sometimes it was only 1 year or maybe less.
Thank you very much. And do you perform, or in the scientific literature, those reports or studies that they are handling the same topic, do they or you perform any kind of additional imaging during the assessment of a given time after the implantation?
Can be, especially in the second study. Maybe we will find studies which include imaging, but for example, in the first study, where I see already the data and the publications, they don't really use imaging, so only clinical aspects.
That's okay. Okay, thank you.
Thank you very much.